Hello, in this short video I want to actually talk about how you document the results of a CRMA. First of all, what you're doing with the CRMA with spinal kinetics is you're determining the severity and location of the non-disc ligament injury. Now, what the results of the CRMA immediately allow you to do is grade the severity of the sprain. So sprains have three severities: grade 1, grade 2, and grade 3, or you could say mild, moderate, or severe. And so a grade 1 sprain has no excessive motion, no detectable excessive motion. A grade 2 sprain has abnormal excessive motion, and a grade 3 sprain has significant or severe excessive motion in the joint. So when we say severe excessive motion, we can sometimes call that rateable, which means that it has its own category in the impairment guides for classification or placement under what's called alteration of motion segment integrity, which is a specific amount of excessive motion, 3.5 millimeters of translation or more, greater than 11 degrees of angular difference, and or 20% of actual slippage. These are three different ways that you can determine a significant or a severe amount of excessive motion. So it immediately allows you to grade the sprain. So if you're grading the sprain, you're basically, even though there is no ICD-9 classification for mild, moderate, or severe sprains, it tells everyone involved with the claim itself what is the severity of the sprain. And obviously the more severe the sprain is, the more treatment that can be required, the more permanent it is, the more negative effects it could have based on the patient and what the patient's previous history was all about. Now, the other thing you're doing is you're immediately determining if you've got a surgical level of non-disc spinal ligament injury right away, based on insurers' guidelines. And if you don't know what those insurers' guidelines look like, just go to the resources page on our site and Spinal Kinetics, and you'll see what those resources are. You'll see it's 3.5 millimeters of translation, or greater than 11 degrees of angular difference, or 20% slippage. And in some cases, some insurers, some health insurers actually have lower levels that qualify for spinal fusion surgery. So you're going to document that. Hey, the patient has a level of non-disc ligament injury that is qualified for pre-authorization for spinal fusion surgery. We're going to start a stabilization program to avoid the surgical need. Simple documentation. It also gives you immediately what's the level of impairment. Do you have a 25% impairment? Do you have a 5% impairment? What is the level of impairment? If you have automatically qualifies for an impairment level, then you're going to give that impairment level. If it's a lesser impairment level, say you have abnormal findings, but those findings are causing asymmetrical range of motion, you would have a 5% impairment. So it immediately allows for placement in the surgical guidelines. It immediately, and you're just going to report what that impairment is at MMI. Remember, if you have a compression fracture, a 10% compression fracture, it qualifies for a 5% impairment. That compression fracture is permanent. The thing is with the non-disc ligaments is once they hyperstretch, they're permanently hyperstretched. They don't go back. So the joint itself may degenerate because they do accelerate the degeneration, so you may take out long-term through degeneration that excessive motion. But it's a permanent condition, and it has a permanent sequelae that comes with it. So you can also, once you have an excessive motion study, it's going to tell you, do you have the need for athletic return to play parameters to kick in for athletic restrictions on contact sports. And contact sports could be jiu-jitsu, it could be kickboxing. I mean, a 19-year-old girl that's in an auto accident has 2 levels of surgical level ligament damage and kickboxes 3 times a week, probably shouldn't be going to kickboxing. So it correlates with national guidelines for activity return to play parameter guidelines for contact sports. It immediately allows for placement and treatment guidelines. So there's treatment guidelines out there such as chiropractic Croft treatment guidelines, there's surgical guidelines, there's athletic guidelines, there's guidelines. Every profession has their own guidelines for treatment. I'm going to use the ones for chiropractic right now. It immediately allows for placement in the Croft treatment guidelines, which allows for more care on a more frequent basis. So treatment change could be, hey, I'm going to need 3 times a week care for 2 months instead of 1 month. That's a treatment change based on the results. So It immediately allows you to communicate that, though. It immediately allows you to communicate, hey, wherever you have abnormal or ratable or significant intersegmental motion, you have a facet injury. You have a facet problem, potentially. So the facet caps or ligaments are deeply involved with the posterior ligament complex. And so if you have excessive motion, you have a problem with those facets. We have out on our YouTube channel, we actually have an animation of these injuries. You can go look at the injury, and when you go to extreme angulation or you go to stream translation, you will see that the caps or ligaments are hyperstretched. And when they hyperstretch, obviously they inflame right into the vertebral canal, the foramen. And you also have the interforaminal ligaments, which cross over motion units that are highly sensitive to excessive motion. So when you have an excessive motion condition, you also know that the interforaminal ligaments are damaged, and they have no place to swell other than the nerves. If you're not understanding what I'm saying here, go to Spinal Kinetics YouTube channel and look at the animation, and you'll see exactly what I'm talking about. So it tells you where the facet condition is. It also tells you by research. Research today tells us that if you have excessive motion, especially in extension, for translation findings, you have a higher probability of disc herniation. So it drives better disc referrals with a great clinical rationale for why you're doing the disc study in the first place. You got to remember, there's only 3 ways you can damage a spine or derange a spine, which is fracture it, excessive motion, or disc herniations, or combinations thereof. But a disc herniation unto itself is basically considered to be a pre-existing condition, because there's a lot of tissue that the force has to go through to hit the disc in, say, an auto injury. And if that tissue is not damaged, but the disc is damaged, that disc is considered to be a pre-existing condition. So you got to have the other tissue damage around the disc herniation in order to assert that it's caused by the trauma itself. The last thing, so basically I get back to test results. Test results say, hey, I got a severe ligament damage at C4, C5, C5, C6. Chances are that I have a disc complication and the disc was damaged with the accident. On 4 weeks, 6 weeks, I will be making a referral out. We're going to treat, we're going to stabilize right now and make a referral out to see what the complication of the disc is. Wow. The level of documentation that I just did with that example there is 10 times higher than what it is in the market today. It's a heck of a lot better than saying, well, you know, gosh, if they don't have a disc injury, they don't have any injury at all. Or that kind of foolishness that's in the market today. Okay, the last thing is the trajectory in a mild traumatic brain injury. So mild traumatic brain injuries have 6 clinical trajectories. So anybody that certifies in the United States on mild traumatic brain injury and is a concussion expert knows that you can have visual problems, you can have balance problems, you can have cognitive problems, you can have anxiety and mood problems, and you can also have headache and the cervical profile. So eye, balance, cognitive, mood, headache, and cervical profile. Now, what's the cervical profile? It's the cervical injury. It's the upper cervical injury. Upper cervical instability, spinal instability, can cause every single one of the symptoms of a mild traumatic brain injury, but the symptoms of the mild traumatic brain injury cannot cause a cervical injury. Headaches don't cause a cervical injury. Visual problems don't cause a cervical injury. If I have a visual problem because somebody poked me in the eye and I got visual problems, it doesn't cause a cervical injury. Okay, if I got balance difficulties because somebody actually popped me in the ear and I got balance difficulties as a result of it, it doesn't cause a cervical injury. If I've got anxiety and mood problems, it doesn't cause a cervical injury. If I've got cognitive problems, it doesn't cause a cervical injury, but a cervical injury can cause all 5 of the others. It can cause headaches, it can cause cognitive problems, it can cause anxiety and mood disorder problems, it also can cause visual and balance difficulties. So it is the most senior of the profiles or the trajectories, and it's the one least known. Spinal Kinetics is helping to lead the way in this market by actually giving the provider an accurate assessment of that particular condition, especially when the patient's taken A to P open mouth lateral bend x-ray and measure how much step off there is between C1 and C2. That does not need to be done by a DMX. It does not need to be done by any video fluoral product in the market today. It's done with straight, simple digital x-ray. One of the most powerful testing procedures there is in the market today, and the most underappreciated is the digital x-ray. The digital x-ray is in every single small community in America today. And it's the most underutilized, inexpensive, which we love the fact that it's inexpensive, imaging tool that there is. And that's what we at Spinal Kinetics are doing, is we're evolving that particular very inexpensive, cost-effective tool to mine more data out of it, to mine more information out of it that's highly pertinent, highly relevant, and really easy to document. Doctors, I hope, the last thing I'm going to say, when you are doing excessive motion testing, you want to do it whenever possible by an unbiased, independent medical group, if possible. Look, the findings are so significant. They have so many ramifications. You have far more tools, and the data that you're getting from an excessive motion testing is far more helpful than even that of the MRI. It's one of the most helpful tools in the spinal injury space today. But the testing results, in order to be relied upon, that there's no provider bias. Providers can actually get into softwares, they can purchase softwares. The softwares may be questionable, they may not be FDA cleared, they may have flaws in them, and the manipulation of the study can be done by the individual providers. So insurers should not accept. They will have a difficult time accepting when it's done by the provider themselves. You're perceived as biased. Spinal Kinetics removes that. It removes that by providing an unbiased, independent third party whose only job is the results, accurate results. And we use FDA-cleared procedures, we use FDA-cleared technology. So if you're out there today and you're trying to do these studies yourself and you're not using FDA-cleared technology, there may be flaws within the procedures. I just simply would not do it. Now, some people would say, oh, that's because you're biased, because you run Spinal Kinetics. I set out with excessive motion to make it a standardized testing procedure and to evolve it. That's why we evolved the FDA-cleared AI that we helped to develop. That's why we do what we do, is to evolve the test into a standardized test. Look, anybody that's in a spinal injury should have this test. And part of our goal and our aim is to make it highly effective, highly accurate, highly reproducible, and highly cost-effective. And in time, the cost of this test procedure will even go down, lower. There are some out there that are putting $200,000, $250,000 worth of equipment to try to determine if a patient has alteration motion segment integrity or not. That's ridiculous. It's done on simple digital x-ray. That's where all of the studies are done, that's where all the numbers come from, and that's what all the guidelines state. So I hope this has helped you to understand exactly what to document and how to document using Spinal Kinetics CRMA.